My name is David Kooby. I am co-chairing this session along with Professor Horacio Aspan. This is minimally invasive pancreatic resection, present and future. And it is my distinct honor to welcome a great panel of speakers to this session. I'm going to actually start with the first talk, and then we'll go through everything. This is an introduction to the session as well as a review of the first international conference that was held in 2016 in Sao Paulo, Brazil on minimally invasive pancreatic resection. So the first talk will be mine on a review of what we did in 2016. Then we have Adnan Al-Saidi, who's going to talk about minimally invasive distal pancreatectomy to preserve the spleen or not to preserve the spleen. He's a local boy from Virginia Mason, extraordinarily well trained. We're honored to have him. Then John Martini, an expert in robotic HPB surgery from CMC in Charlotte, North Carolina, will talk about minimally invasive Whipple. We're very privileged to have all the way from the Academic Medical Center in the Netherlands, in Amsterdam, Joni van Hilst, who's going to talk about what's been done in randomized trials in minimally invasive pancreatic resection. She is very connected, and she's actually running some of them, so we're honored to have her. Next, Rohan Jayaraja is going to, from Methodist in Dallas, a consummate educator, an HPB surgeon, and best dresser that you'll ever meet, will tell us how we train. And then we have Professor Aspan is going to, who needs no introduction, lead a panel discussion. Finally, Pippa Newell, who is also a relatively local person from down the street in Portland, Oregon, at the Providence system, is a really dynamic speaker, and she's going to lead a presentation with questions for the audience, and you should have your question clickers. So this meeting we held in Brazil was in April 20th of 2016 in Sao Paulo, and it was part of the IHPBA conference. It was a standalone pre-Congress meeting. It took 18 months to plan. It had a 16-member organizing committee from 10 nations. It evolved from a consensus conference to more of a state-of-the-art conference because there really was a paucity of high-level data, which is now changing. It was a spark for future meetings, and we had 450 attendees. 50 were faculty who included some non-surgeons, and there were 400 registered. There was no industry support, and this was important because we really wanted to leave this devoid of conflict of interest. This is the organizing committee. You can see it spans North America all the way to Asia. And in order for the people to be on in Portland, Oregon and Seattle, Washington at 5:30 in the morning so that folks could stay on in Asia till 11 p.m. It was pretty difficult. We had monthly conference calls. This was the agenda for the meeting. There was an introduction, which we defined what the key metrics in pancreatic resection we should be analyzing between open and minimally invasive. Then we tried to standardize terminology, and I'll get to that. It's very interesting. We also looked at the results of the first international survey on minimally invasive pancreatic resection. The data-driven portion of the day was on distal pancreatectomy and Whipple, so those were standalone modules, followed by where we are with cost, value, quality of life, how to start an MIPR program, how to define value, and then really understanding what the patient wants. And then we got to training and credentialing. This was a dynamic session looking at video assessment and then widespread dissemination of educating. And finally, we talked about what the future research plans in minimally invasive pancreatic resection would be. There were 4 dynamic panel sessions, distal, Whipple, training, and research. These are available on the MyHPB website, and they're fun to watch if you get a chance. So we know that the number of publications in minimally invasive pancreatic resection skyrocketed over the course of 20 years, and it's gone up even further since then. The problem with this, though, is when you look at the title of a lot of these papers, they're replete with terms like full laparoscopic, totally laparoscopic, total laparoscopic, hybrid. What is hybrid? We don't know what that means. Mini laparotomy. I guess it depends on the size of the incision and the size of the person. Robotic and then robot-assisted. So how do you make sense of this? So we used a Delphi process to come up with a way to look at this. Avoid unclear terms like total, pure, hybrid, and mini laparotomy. Link procedures, methods. Maybe you do a laparoscopic resection, but you do a robotic reconstruction with the preposition with. Describe a conversion with the phrase converted to, because it has to be deliberate, and then designate this conversion as urgent or non-urgent. So we came up with a framework which is published in HPB in the March 17th issue, and this framework, I don't spend a lot of time on it, but if you use a solitary approach, a combined approach, or a conversion, it should have a very specific way of doing this so that when you look at the studies, you can compare apples to apples. Then the international survey was led by Mark Besselink in Amsterdam, and he used a Google Docs survey method and sent this out to all the societies you see there. He got responses both from open and MIS surgeons. There were 61 questions relating to MIPR, and they applied to these things: experience with pancreatectomy and MIPR, attitudes towards patient selection, learning curve, cost and quality of life. It mimicked what our day was going to be for this meeting. And so we had respondents from all these different countries, over 100 from Asia, even 3 from Africa. A total of 435 responded, and 21%, or 90, were non-MIS surgeons. Here's a sample. So we looked at 435 responses on minimally invasive Whipple. So the first category is if you're not performing a Whipple. This was 311. What were the reasons why you were not doing it? And so things like lack of training, difficulty with surgical technique, lack of time, cost too high, et cetera. And then for those who did do Whipple laparoscopically or robotically, 124, then it defined whether you did them fully laparoscopically or laparoscopic with open reconstruction, et cetera. And so this is the type of answers we got. This is not a static issue. We do this survey again, I'm sure the numbers would be quite different. Then we moved on to the data portion of the day, data-driven portion, and we looked at Whipple and distal. We looked at perioperative outcomes and cancer outcomes. These were the speakers. And here's a summary of those modules. So if you look at the MIDP as distal pancreatectomy, MIPD as Whipple, we saw the operative times were longer for Whipple, but not for distal. We saw that blood loss was lower in both the MIS approaches as compared with open approaches, maybe fewer complications in distal, but perhaps similar in Whipple because it really is about the reconstruction. And then length of stay shorter in distal, and at least right now in Whipple, pretty similar. Cancer outcomes, really only difference we saw was an increase in lymph nodes with an MIS approach. When we looked at cost data, really this was problematic. Well, we have limited low quality evidence, single center, selection bias, no accounting for the investment in the actual program. $2.5 million robot, you can't just sweep that under the carpet. It is a huge cost. And then it was really difficult to compare centers and challenging to compare things being done in other countries. MIDP appeared to be cost-effective from the small single-center studies that were out there. Why? Because there's a trade-off between technology use and a shorter hospital stay. It was at this point impossible to assess the cost value of MIPD, and there truly was no analysis of value, because value is not just shorter hospital stay, it's a patient outcome over a dollar value in order to generate that metric. So this was startling for everybody and really important. Julie Fleshman, who is one of the smartest people I've met, she's a JD MBA. Her father died of pancreatic cancer. She made it her mission to address this issue. So she leads the PanCan, the largest pancreatic cancer advocacy group. And her big statement to us was, the patient with pancreatic cancer is asking for information on who can do my operation well and what are my chances of survival. And at that point, very few were asking about laparoscopy. So we have to carry that. We have to own that. Are we doing this for us? Or are we doing this for the patient? And so that's some of the things that still need to be fleshed out. Breeze through this. This is a graph of the HPB fellow experience 2014 to 15. The bars represent the total number of distal pancreatectomies at each of the programs. The orange part are the laparoscopic, the green are the open, and the sort of the brownish color are the robotic procedures. And you can see there's a smattering throughout. Now, if we go here and look at Whipple, very few programs were teaching robotic Whipple or laparoscopic Whipple by comparison. So how do we How do we train our fellows? How do we train our young surgeons to do this? Well, we can go to the model of how athletes train. They do video assessment. They look at their outcomes, and they come up with best practices. And so the group in Pittsburgh has really led this by showing how you can break down the steps of training into 5, and you can walk people through a curriculum all the way through. So mastery of the console, mastery of loss of haptic feedback, mastery of the procedure itself, then coming back to psychomotor performances, and then decision making. And that you could take somebody through these steps, and it's reproducible, and you can train them. So by this category, we have 3 surgeons, Herb Zay, Amr Zerkat, and Melissa Hoag, who until recently were all at Pittsburgh. So Herb basically had no training as a resident. He didn't train as a fellow with robotics. He didn't have a CME course. He didn't have a simulator. He didn't have a mentor. It took him 80 cases to achieve his learning curve. Zerkat had a mentor, got down to 40. Melissa Hoag had all the things that you see circled. She learned to do robotic Whipple in 20 cases and is one of the few people in the world who's done more robotic than open Whipples. Mark Besselink again demonstrated how you can teach this to a nation. He taught this course, 32 surgeons, 17 centers in the Netherlands. They all learned how to do the case the same way. And this has been very valuable. And you'll see in Joni van Hilst's talk about prospective randomized trials and how they're able to do this. The last session was on research and taking us through the ideal framework. There's a picture of Jeff Barkin, who was on the original Lancet paper that described the ideal framework, and basically take an idea, turn it through development, exploration, assessment, and long-term study. And so now MIPR is getting to the later phases of this ideal framework in surgical innovation. So this is James Garden, who is the editor-in-chief of HPB. He has his hands around mine, and Chuck Vollmer, who was my co-chair of this entire event. He's ready to choke us if we didn't get our papers in, our manuscripts in from the day, but we did. And so all of these papers shown right here are published in a single issue of HPB. You can go back and look at it. This is our organizing committee, great group of people from around the world. And finally, what was missing? Well, this, as I said in the beginning, was a spark for future efforts in MIPR. We did not discuss technique and other particulars. You're going to see some of that today. Splenic preservation, laparoscopy versus robotics, and this field is moving very quickly. So I'm honored to be up here with Professor Asbun to introduce the rest of the day. Next speaker is going to be Adnan Al-Saidi, who's going to talk to you about distal pancreatectomy and preservation of the spleen. How to and should we?